Hi, and welcome to Adventures in Relationship. I'm Amy Gordon, a psychotherapist residing on unceded Tiwa land outside of Albuquerque, New Mexico. I'm a pact-oriented couple therapist, and my individual therapy toolbox, you could call it, includes feminist, adventure, internal family systems, DBT, somatic experiencing therapies, among others. I'm a disabled, anti-Zionist, Jewish, queer femme. And today I want to talk about mental health diagnoses and complex PTSD. Ever since I was little, I've been fascinated by psychology. My stepmom is actually a psychiatrist, and I remember reading Freud's literature as early as 8 years old. I was fascinated by his interpretation of dreams. We actually had a dog named Sigmund, and I worked at my stepmom's psychiatric practice part-time when school was out, like over the summer and school breaks, from ages 12 to 18. And I loved peering into the contents of client files. I mean, even just the structure of them, but I learned a little bit about diagnoses and symptoms from an early age. And I really enjoyed talking psychobabble with my stepmom. I am a little bit of an integrative and alternative therapist. And, at the same time, and sort of in contrast, my mom was into occult material, self-help books, tapes, and videos, like were all around when I was a kid. So I was learning about not only the clinical aspects of human complexity at my dad's house, but I was also watching Wayne Dyer and hearing about how men are from Mars and women are from Venus, and reading about personality from the lens of astrology, in addition to like some other different lenses and stuff at that time too. So all throughout my childhood and adolescence. In psychology, all right. I took psychology in high school. That's what I'm trying to say. And I loved it so much that I ended up obtaining a position as a student assistant for my psychology teacher, still my favorite teacher to this day. Anyway, he let me take advanced psychology twice, even though I'm sure I got an A+ the first time, but he let me do independent study on transpersonal psychology for the second round. And I've just always really been fascinated by human behavior. So, there are other reasons for that too. I also experienced chronic and complex relational trauma starting in infancy, probably, which is also an incredible motivator to learn about psychology. In fact, a lot of helping professionals come from backgrounds where they had to unconsciously and or covertly learn about human emotion to basically survive their childhood. So, interestingly, because getting what do you call it, a medical degree? Being a medical doctor and the education that goes into that is very extensive. I know my stepmom was in school for like 12 years to be a psychiatrist, but interestingly, none of my other parents went to college, so I didn't get a lot of guidance on the matter. But at the time, I honestly thought that getting a bachelor's degree in psychology would make me a psychologist. And that's embarrassing to admit, but the process of pursuing college is really confusing without much guidance. Anyway, it took me 10 years to get my 4-year degree. I couldn't afford it with no financial support, trying to pay rent and trying to do college full time. While working full time, and those jobs were toxic and abusive, as a lot of entry-level jobs are. I endured an awful breakup at 19, and I started coming to some painful realizations about how fucked up my childhood was. I ended up having a complete mental breakdown, and I dropped out between the first and second semester of my sophomore year in college. That last semester of my first round of college, because I did go back, happened to be the last semester they were offering a course on transpersonal psychology. That professor was retiring, and no other professor would be taking it up. So, in retrospect, this really doesn't feel like an accident to me, as part of the experiential portion of the class entailed having to engage in a spiritual practice. I was already meditating with a Zazen group at the local Unitarian church, so I decided to check out A Course in Miracles. And the next few years of my life were filled with peak experiences, adventure, experimentation, tons of additional reading of self-help, spiritual, and psychological literature. So I kind of never stopped learning, but I needed that break from college. And I finally went back to school at the age of 24. And at that time, I started working with adults with disabilities to get through school. And I got my first big girl job in social services when I graduated with my bachelor's degree in psychology in 2012. I worked in human services institutions for a few years, and I decided to go to grad school, not because I wanted to be a therapist. I had actually given up on that because I thought I was too much of a mental health mess myself to help anybody else, to be honest. And I've also heard that from a number of other clinicians that they were like concerned about their own ability to help, given how damaged really they felt. But I have done a lot of healing work since that time. Anyway, I was just hoping to obtain a master's degree so I could get a higher paying job. And going to school for counseling seemed like the most attainable way for me to get a master's degree since I had been basically studying the field my entire life. So I moved from the Midwest to Santa Fe, New Mexico in 2014, and I went to grad school half-time over the course of 4 years so I could maintain full-time work and support myself. And after 2 years in the field, I was hard pressed by my employer. So this is, after I finally graduated. And after I'd been a therapist for 2 years, I had an employer who was really encouraging me to do the advanced testing to obtain my independent licensure so I could get credentialed as a clinical supervisor. So I did that, and I spent 3 years as a clinical supervisor, and I'm still technically credentialed as such, but I don't really want to do clinical supervision anymore. So I'm not going to renew when my licensure renewal is due in September. I'm not going to renew that credentialing. But between my last year in grad school, the intensive clinical supervision I received as a non-independently licensed clinician, and I guess in addition to kind of a lot of that encouragement I got from all of those leaders, those clinical supervisors, and a lot of the training I received, I guess how would I say this? I became a real hard ass about diagnosis. So there's just a lot of really kind of scientific materialism messaging about diagnoses. I kind of got them. I knew a lot of the symptoms. I knew a lot of the diagnostic categories and criteria. So, I learned it. So I kind of became a hard ass about it. And when you're studying for that test for independent licensure, you basically have to memorize the DSM. But I really maintain that in a way that I think a lot of clinicians don't. They kind of, pass the test and toss it out the window. But in some regards, like they just kind of tend to diagnose their clients with one of the same 5 diagnoses, like, oh, major depressive disorder, generalized anxiety disorder, kind of more common ones. But I was known for being kind of rigid in this regard, being a hard ass about diagnosis with my supervisees. And I required my supervisees to cite specific diagnostic criteria for any prospective diagnosis. And I knew and still know most of the detailed symptomatology for nearly all diagnoses in the DSM. And I encouraged my supervisees to do the same. Of course, I had a framework for understanding symptoms and diagnosis since I was very young, but the more experience I have in the field, the more flexible my understanding of the importance of diagnosis becomes. And that's really what this episode is about. I've had a number of clients, come in with very clear and demonstrable symptoms of more common disorders. The 2 I mentioned before, generalized anxiety disorder, major depressive disorder, dysthymia, panic disorder, PTSD, substance use disorders. Those are kind of more common, but I'm noticing more in the past few years, clients who, after a few sessions, start alluding to wondering if they have ADHD, autism, or bipolar disorder, just as a few examples. And pretty much nobody pretty much nobody thinks they have a conduct or delusional or personality disorder, by the way. Um, Although I think of the show Crazy Ex-Girlfriend, where Rebecca is singing and thrilled to have finally gotten a diagnosis of borderline personality disorder. And I know this is totally a tangent, but it wasn't the worst depiction of the disorder, but it wasn't really the best either, or most accurate. But anyway, for the most part, there have been significant increases in the prevalence of mental health diagnoses lately. And for the most part, I think that points to a number of problems in our field. The diagnostic materials are often being misused. Interpretations of criteria are stretched or loosely interpreted. I mean, in the first place, diagnostic manuals are inaccurate to some extent. And there have been significant changes in access to assessment, you know, in the recent history that have also kind of affected rates of diagnosis. But also, maybe the most significant factor is that social media has greatly influenced and in some cases distorted information about certain diagnoses. It's important to me to mention that I'm not into gatekeeping information about mental health. And some of my contemporaries are, and that's really not what I'm trying to do here. All in all, I'm thrilled about pop culture discussions of mental health, but social media has definitely influenced people's knowledge and lack thereof about mental health topics, for better or worse. And that's definitely contributed to the trending of certain diagnoses. For instance, autism, at least rates of autism diagnoses have increased over 100-fold since the early 2000s. Asperger's syndrome was removed from the DSM in 2013, and that's definitely a factor. But also neurodivergence is becoming more widely acceptable, I guess is the word, and even valorized in some cultures. And I've truly witnessed some people wanting the diagnosis so that they could better fit in with their neurodivergent peers. And I don't think this is a bad thing innately, but I do experience some concern about those with more severe disorders not being taken seriously, as our collective interpretations of diagnostic labels become excessively watered down in some instances. There's this book called Saving Normal, where the author demonstrates how he demonstrates basically that pharmacological entities have essentially driven diagnosis trends over the past 30 years. And that's something really interesting to keep in mind, how much the pharmacological industry has really affected this field. And I'm not going to get into it today, but there is some really concerning neuroscience research about the fairly ridiculous lack of knowledge in the medical field as to why and as to how certain psychotropic medications work, and that they're rarely more effective than the placebo. There's this author, Joanna Moncrief, who writes about this in a book called The Myth of the Chemical Cure. And she has a number of other books too. And I'm not a total like woo-woo quack when it comes to medication. I'm actually on a combination of antidepressant medications that work for me. But I had to try at least 8 or 9 different medications over the course of 6 years, suffering worse side effects than the symptoms I was having in the first place, before finding something that actually helps me. And if you want to do an experiment, just ask your prescriber which serotonin receptors are affected by various antidepressants, and they'll probably squirm. There are at least 7 types and 14 subtypes of serotonin receptors in the human body. And how do you say this word? Serotonergic, there we go, serotonergic medications all affect different combinations of receptors. And yet prescribers typically just dish out the most popular, i.e. massively advertised medications on the market. And it's not just SSRIs, SNRIs, or SNRIs and the like. There are also really concerning and fucked up histories behind other medication types, antipsychotic medications, for instance, that Joanna Moncrief has another great book called The Bitterest Pill that's worth a read if you're interested. But I digress. So Anyway, there is another book by Gabor Mate and his son called The Myth of Normal, which also illustrates how arbitrary diagnoses often are and how the vast majority of common diagnoses can be more accurately and sensibly attributed to the functional systemic response to complex trauma. That's what I really want to talk to today. So in case you aren't aware, complex PTSD, or complex post-traumatic stress disorder, it's not recognized as a valid diagnosis in the United States. A lot of people are pissed about that, but the primary reason that it's not is because the symptoms are too broad. They're too diffuse for the steering committees to really be able to agree on core criteria. That is to say, the fact that CPTSD is not in the DSM is evidence to support the idea that mental health symptoms are, by and large, natural nervous system adaptations to environmental and relational stressors of our upbringing. So many symptoms, from inability to concentrate, low self-worth, difficulty with executive functioning, obsessive thinking, difficulty sleeping, appetite problems, and just to name a few, cross over from diagnosis to diagnosis. So when I say those symptoms, low self-worth, difficulty with executive functioning, obsessive thinking, difficulty sleeping, appetite problems, and social relational issues, what disorder do you think of? Interesting question, because it really could describe a person with any number of disorders: anxiety disorders, depressive disorders, ADHD, and a number of others. Diagnoses are often kind of a shotgun smattering of common symptoms that come about from chronic hyper or hypo-aroused nervous system states. And I'm not saying diagnoses aren't important or helpful. I think that they can be, most notably because the only way insurance will pay for therapy or psychotropic medication is through having a documented relevant diagnosis. But also, it can be helpful for gaining a preliminary understanding of the particular cluster of symptoms you experience, tracking and treating symptoms on your healing journey. It's a more efficacious approach to recovering your ability to engage in life than clinging to a label. So, that is to say that, thinking of your symptoms versus thinking of a disorder can be more helpful. So I guess what I'm trying to say is, really focusing on the symptoms that you're having can help you engage in life and can really help you determine kind of what healing work you need to do. And it's just that clinging to a label can reinforce the belief that you're born this way and you're never going to change. And that's not necessarily true. In fact, I think it's unlikely if you're really doing your work. And I will share that I have a number of documented mental health diagnoses myself. I take psychotropic medication for the symptoms I experience, but the more I come to understand complex trauma, the less the diagnoses are actually a helpful framework for my healing. So, like I said, I look to the symptoms I experience and I come to understand how and why I developed them as an adaptation in my childhood. But for me, and really for everyone else, it's a process of bringing to consciousness the unconscious fears, beliefs, and protective mechanisms that have been driving our nervous systems. So realizing these patterns, or realizing that these patterns no longer serve us, and engaging kind of the unfortunately long process of allowing neuroplasticity to reshape our nervous system, it's, that's what happens as we make changes in our life. And that's really what we call healing. So we have to make the changes, our brain changes in response, and we experience healing. So like I mentioned, I do take medication, but I don't think of it as a lifelong need. Rather, kind of as a supplement to support brain and nervous system recovery, like until the new neural pathways are strong enough and the neuroreceptors are functional enough to compensate for the way they had to function during my development. Another thing diagnoses can be helpful for is for prescribers in determining what medications to try. So it kind of gives clinicians and prescribers a snapshot of what might be happening in the brain and nervous system. and having an explanation as to why certain things are more challenging for some than for others. That can also be helpful. We can also explain our limitations to the people in our lives. We can explore more specific support options when we have a diagnosis. So I'm not saying just trash diagnoses, but I think it's helpful to kind of zoom out and look at the concept of diagnoses from a broader framework. And that's what I tell my clients. When they're curious if they qualify for a certain diagnosis, I let them know that it can be helpful, but I ask them why they want to know and what they hope they can get out of knowing. I do caution against getting too attached to a specific diagnosis. I say, you might not want to let this define you, that your truest identity really has nothing to do with a mental health diagnosis. And I help them identify the patterns from their childhood that led to their nervous system adapting as it did. And then I support their practical healing journey, which is a lot more nuanced. I usually do a preliminary diagnostic screening with them and discuss the findings with them. And I offer referrals to specialists or prescribers and to different support options as appropriate. But I also share with them that the recovery work for their symptoms is the same with or without a diagnosis. They still have to learn to manage stress, practice coping and self-care, do relational work with their partner, whether or not they have a partner, and heal their attachment wounds. They might need medication to increase their functionality while they make the necessary life changes that can actually lead to permanent neuroemotional recovery. Some people think of this as derogatory, but I totally think of medications as a crutch, and there's no shame in using crutches when you need them. So the big takeaway I'm hoping you get from this is to know that more progressive research and leaders in the fields of medicine, neuroscience, and psychotherapy are starting to think along these lines, to conceptualize nearly all mental health symptomatology is resulting from adaptive complex trauma. And the topic is really controversial. There are certainly instances of mental health disorders that don't seem to be explainable in this regard. But one thing you should know is that there are a lot of intergenerational genetic markers for mental health and addiction that are now known to only be triggered or flipped on as a result of certain trauma. So the field's always developing a greater understanding of the mysteries of the human mind, and I encourage you not to get too attached to concepts or conceptualizations of mental illness just because well-established and, quite frankly, capitalist institutions of scientific materialism and so-called experts say so. And well, I think that's all I really have to say in the matter, but, just kind of the wrap-up reminder to get help locally or online if you're struggling. I'm a therapist, but I'm not your therapist. Please don't rely on any podcast or webcast as your primary mental health support. Take good care of yourself, and thank you for watching or listening. Till next time.